Good afternoon, everyone, and thank you for joining us for today's webinar. This is an informational webinar on UW Project ECHO, Addiction and Comorbid Conditions, Enhancing Prevention and Treatment, also known as Project ECHO Accept. Our presenter today is Dr. Randy Brown. We're here at the Great Lakes Addiction Technology Transfer Center, the ATTC. We're funded by SAMHSA to serve the behavioral health workforce in HHS Region 5, which covers Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. Our center is based at the UW-Madison, where we are part of the Center for Health Enhancement System Studies, which is also home to our partner projects, the Great Lakes Mental Health and Prevention Technology Transfer Centers, as well as NIATEX. A couple of housekeeping items for you today. Want to let you know that this webinar will be recorded, and the recording will be available on the Great Lakes ATTC website and YouTube channel within a couple of weeks. And on the screen you see our web address where you can find it. We also want to clarify that this is an informational webinar about Project ECHO Accept. It's not a session in the Project ECHO Accept series. We will not be awarding CE credits for this webinar. Also, please keep in mind that today's audio is being broadcast through your computer speakers, so make sure that they are turned on and up. You do not need to dial in. And please use the chat feature throughout the webinar to ask Dr. Brown your questions. He'll be answering them as they come in. And we'll also, if time allows, we'll have additional questions at the end after his presentation. And I'd like to tell you a little bit about Dr. Brown. He's an associate professor at the UW-Madison Department of Family Medicine. His primary interests revolve around the treatment and prevention of substance use disorders and their complications in settings outside of the specialist treatment environment, such as primary care, hospitals, pharmacies, and criminal justice settings. His interests revolve around the treatment and prevention of substance use disorders, and he's board certified in family medicine and addiction medicine. He's also the founding director of the UW Addiction Medicine Fellowship Program, the director of the UW SMPH fourth-year clinical addiction elective, and medical director of the overdose prevention program of the AIDS Resource Center of Wisconsin. He's director of the American Board of Addiction Medicine and the Addiction Medicine Foundation, and president of the Addiction Medicine Fellowship Directors Association. Dr. Brown, would you like to take it away?
I will. Thanks so much, Maureen. Appreciate it. And thank you, the ATTC, for the opportunity to join you all today. Many of you may have heard some about the Project ECHO model, and I'll be talking a little bit about implementation of such a model targeting substance-related issues here in Wisconsin. So, to ensure that everyone has a shared understanding of what ECHO looks like, I want to start by going over a brief history of that model, its founding, its philosophy, and what the model looks like in broad terms. I think it can be a little difficult sometimes to get the head around, so for purposes of enhancing that understanding and perhaps breaking up a slide presentation a bit, I've got a couple of videos that we'll be queuing up that will hopefully enhance understanding so far as that goes by way of the ECHO model in general terms. And then I'm going to move into experience with the ECHO model, particularly here, so folks can understand what it is that we're doing with that model here and can answer any questions about what it looks like here, or questions about perhaps getting your own model going in your own area, if that's of interest. So Project ECHO was initially founded at the University of New Mexico back in 2003 by a hepatologist by the name of Dr. Sanjeev Arora. Many of you likely know that for many years, New Mexico has had one of the more serious problems around injection drug use and heroin use nationally. And in fact, the county with the highest incidence per capita of opioid overdose arrests in New Mexico. Related to the injection drug use prevalence in that area, New Mexico also has quite a high prevalence of hepatitis C. And Dr. Aurora was inspired to create the ECHO model by the fact that he was often seeing it take patients a long time to get to him for consultation and ultimately treatment for their hepatitis C, and he was seeing more advanced disease by the time they arrived to him, and so he started thinking a bit about how technology might be leveraged to get primary care providers perhaps up to speed in providing this treatment. And so by way of a first video, we'll get that queued up, which is of Dr. Aurora talking a little bit about his inspiration to get this model going.
There is a specialist shortage worldwide. We had to innovate a new model. Project ECHO allows specialists like me to force multiply expertise. I think that's why it works, because it's very simple. And that's actually why I could come up with an idea like this, because it was simple. In 2003, there were 30,000 patients with hepatitis C in New Mexico. I didn't have enough time to see everybody, and that led to a lot of soul searching. What is the way that I can have a bigger impact than the patients whom I just see in my own clinic?
Well, the 1025 was 10.
It just came as an idea. Skype was available. I talked to my daughters on it. Seeing this technological revolution unfold was probably a background knowledge that I needed to come up with this idea. In 2010 alone, we have trained more than 1,000 healthcare clinicians on our video conferencing platforms. Nurses, primary care doctors, physician assistants. Uniformly, every single ECHO project that we've started, the specialists find it extraordinarily rewarding sharing their expertise to improve the health of underserved populations in the United States and ultimately all over the world.
So in order to get our ECHO off the ground, we were required to go to an orientation session of 3 days at University of New Mexico and the ECHO Institute and learn a little bit about the philosophy behind the model and how best to implement it and maintain fidelity to the philosophy of the ECHO model. A, B, C, D. The idea is to apply technology to leverage scarce resources, have outlying providers learn from specialist expertise, and specialists learn from best practices being established in the community, and outlying providers to learn from one another in order to reduce disparities. The crux of these clinic models is really the case-based learning, where providers will call in and they'll bring cases with which they may be struggling or feel they need advice from others. And the cases are discussed by attendees and ultimately recommendations given back to the provider around addressing a patient's needs surrounding a particular issue of medical complexity. And the ECHO model also includes some requirements around our reporting information around attendees, what their training backgrounds, credentials might be, and their satisfaction with the sessions and other sorts of material that they might want to see in the context of these sessions. So the idea to which I've already alluded and Dr. Aurora alluded is a lot of times patients, particularly in more remote areas, though not universally remote areas, often have challenges to getting to specialty care. There aren't enough specialists to address all needs, particularly when we're talking about substance use disorders in some of these outlying areas. And so these echo sessions and through case-based presentations as well as some didactics are working to get primary care clinicians up to speed in providing aspects of care that they can handle in that setting, because they can likely handle more once they have the right information. And our next video gives you a little bit more of a sense by way of that philosophy and goals.
Project Echo is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centers and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under Echo, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. Echo exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project Echo, changing the world fast. Join us at echo.unm.edu. Are you part of the Echo?
One thing that can be a little confusing, particularly for those in healthcare, is distinguishing the Echo tele-educational model from telemedicine. So Echo sessions are not telemedicine. The specialists at the central Echo, what's frequently referred to as a hub, aren't directly engaged in patient care or interfacing directly with patients. The primary care provider is coming in with de-identified information, presenting it as a case for advice, much like for those familiar, say a tumor board or something along those lines, to get evidence about medical management in the setting of a particular patient. And this is the way typical clinics look. They can vary in duration from an hour to a half-day clinic session. An aspect of the clinic session that the Echo Institute really emphasizes is a building of the community of learners. And so introductions are recommended at the outset of each session so that the learning community can get to know one another, their roles in client care. Then this is followed by the majority of a session typically being, as I've already mentioned, case presentations. And perhaps I can get to the group our template that we'll provide to providers that gives them some guidance around the sorts of information that might be helpful to prevent, so that attendees can give the best advice around patient care. Then there's fairly extensive discussion by all attendees, and ideally some consensus is achieved by way of some recommendations for forward movement with the patient's care. One of the benefits of attendance to Echo sessions is the provision of continuing education credits free of charge in most Echo setups. This tends to be fairly brief, with, again, the emphasis really being placed on the value of learning through case presentations and gaining some familiarity with managing issues of some medical complexity or psychosocial complexity. We also request evaluation and feedback in an effort to continuously improve the sessions that we're delivering, get a sense of needs so far as future topics and things along those lines, and then administratively we'll debrief as a group at the center. So I want to pause for a second. It sounds like folks are still having trouble hearing. Is that the case? Okay, yeah, I'm talking into the phone again.
So it sounds okay from my end. If any participants are having difficulty listening in, could you please try using earphones? We have found that to have helped in the past.
Okay, I'm still going to pause by way of moving forward with content, but I'm going to just talk and babble for a little while to see if this sound issue is coming online for some folks. I'm seeing a couple of different comments. Sounds like a couple folks are hearing okay, but that some others are not.
Yeah, for the folks who are having difficulties listening in, try using earphones and make sure that if you're not using earphones that your audio is turned on to the loudest. You'll see at the top there's the speaker icon. Make sure that's also turned on, and you can also adjust the speaker volume if you hit the triangle button beside it. You can click that and hit adjust speaker volume, and that may help.
Okay. It sounded like some folks might have been having trouble hearing you. Maybe you should talk on the phone real quick.
Hi, everyone. If you're having difficulties listening in, try clicking the triangle button beside the speaker icon, and you can adjust your speaker volumes from there. Otherwise, make sure that your computer speakers are turned on to the max. And also, earphones may help. And okay, someone said that's super clear now.
Okay, good. Sounds like we've got it, I hope. We will march onward. So this is a photograph from the Echo Institute at University of New Mexico, so you can see what's referred to as the hub team. Sometimes that language is used, sometimes confused with the hub and spoke model. I think we're still actively thinking about how that language might be adapted for this, because it is a bit different from how that language is typically used. The format used is, many of you may be familiar with the Zoom platform, and so when we are at Central or the hub, this is the view that we get. Folks can just phone in. We generally encourage video, again, in the spirit of fostering that community and familiarity as participants return to the forum. The recommendation at the Institute as we went through training was to try to keep attendance to around 30 sites. And as you can see here, certainly more than one individual can participate from each site. And that isn't necessarily a hard ceiling, but the reason that's generally recommended is due to limitations around simultaneously visualizing sites and that limit being at about 30. You also start running into, as you might imagine, challenges around getting in all the introductions in a timely manner at the front end of the session if you're exceeding much more than that. So those are a couple of reasons to be thinking about limiting participants at specific sessions. I found this pretty impressive as you look back at the history of ECHO that Dr. Aurora led this paper around results related to primary care management of hepatitis C virus infections, where they found viral clearance rates pretty comparable in primary care settings where providers had attended echo sessions when those were compared with specialist treatment at the University of New Mexico. So that finding is impressive, but perhaps equally impressive is that such a community-engaged piece of work was published in a top-tier journal like the New England Journal of Medicine, where, to my eye, you more frequently see more basic science kinds of articles. So it was good to see this get out there to, a venue that's widely paid attention to by primary care and medical care generally. The model is spread quite widely, as you can see by this global map. Many sites in the United States as well as abroad, targeting many different issues of medical complexity. And each echo tends to focus on a fairly specific issue. And this is just a partial list of what the different echoes may address in the course of their discussions and didactics. So antimicrobial or antibiotic stewardship and appropriate prescribing, asthma, bone health, chronic pain management, perinatal health. HIV management has become quite widespread, and a large number of those international sites that you see are pretty squarely focused on that issue. Rheumatology, many others. But ours, as we've already made mention of, is focused pretty squarely on substance-related issues and substance use disorders. And the way this got off the ground here, we'll send out thanks at this point to the Wisconsin Department of Health Services and SAMHSA under the Opioid State Targeted Response Dollars. Call for contracts proposals went out, to which we successfully applied and received funding in order to get our echo off the ground, and that supported our attendance to the instructional conferences at the University of New Mexico, provides some support for coordination of the seminars and marketing, as well as IT support for the sessions. So the goals initially, as we got this going, it was under the state targeted response dollars. And so we were pretty squarely focused on opioid-related issues as we first got going in 2018. We gathered a team that had expertise in addiction medicine, in addiction psychiatry, in general psychiatry, psychology, pharmacy, pain medicine. We had counselors in social work. We also had participation from DHS and our state opioid treatment authority that was particularly helpful and interesting, and I think gave kind of a different realm of expertise and learning for providers that were beginning to engage in medication-assisted treatment. As a participant makes mention of in our chat function here, that MAT is something we were definitely targeting as a part of this echo session. As providers in our state, outside of specialist treatment environments, only recently have we really seen a pretty major uptick in acquisition of that waiver and establishment of those practices. One of the challenges with the sessions, so my training background, again, is in family medicine and addiction medicine. In part as a function of that, we were focused on trying to get out to primary care settings, but also just due to the fact that under this announcement, among others, there's really a focus on trying to do what we can to reach out to our rural and underserved communities, and primary care and other general medical settings really seemed like the places to target intentionally so far as this goes. And that creates some challenges with scheduling. Busy primary care providers, it can be difficult to find a time that works well. At the Echo Institute, for example, they'll often have full half-day sessions. We found we weren't able to get buy-in to to even 2 hours, initially much less a half day. So as we launched, we'd started with 2 hours, but we soon found that scaling back to just a noon hour was what was going to work best for most participants, and we're doing that currently on the third Friday of each month. We have 1 or 2 case discussions followed by the didactic, and that's how that got going. In the last year, we were able to access a different funding stream to support efforts, again, geared towards supporting more remote providers in prevention and treatment of substance-related issues, and established a consultation provider hotline where we're available to provide advice to primary care providers at the point of care around medical management. And under that funding stream, we proposed expanding our ECHO so that we could bring folks calling in onto that session and share these cases with which they called in and expand on these educational efforts in this context. For those interested in those sessions in particular, this is a snapshot of the website that has information around registering and the URL for that site that will be made available through the ATTC as well. So this is a map of our reach so far. We're pretty excited about this over just over a year and a half of being out there. Did take a little bit of time to ramp up. I'd say in our first 2 to 3 months, we'd have 5 to 10 participants, and now we're pretty reliably up to the 20 to 30 range, and on occasion have had 40. And it's nice to see the geographical dispersion here, and that word is getting out to areas in need. Still some work to do on that front. What you see on this map here in white are counties that are classified as rural according to CMS. And this is really, where we want to get. Opioid use and other use disorders are still an issue in these counties, with methamphetamine particularly becoming an increasing issue. And so far as opioids go, we know that roughly 70% of these counties do not have an opioid treatment program or even a single data wave prescriber to engage in MAT. And as you all also know, opioid use disorders, other substance use disorders, are not uniquely urban problems, and injection use is spreading into our rural communities. This is a demonstration of rates of syringe service access in these communities, and emergency department utilization for overdose with darker gray indicating increased rates. What you're seeing here, rates of increases in hepatitis C, which is getting to be more and more a problem in these areas. And so prevention and linkages to treatment is a major issue for those communities as well. So already made some mention of potential benefits to clinicians. I think to get providers to attend in the context of busy schedules, providing no-cost continuing education is one carrot that can be offered, and that we've been able to do with the funding that we have available. In order to provide fairly broad continuing education credits, we've made sure that we have on board representatives on our curriculum committee from a diversity of fields, including physicians, mid-level providers, social work, psychology, pharmacy, and nursing, so that folks from all those fields can benefit from free continuing education credit. The interaction with colleagues, I've found to be a really rewarding part of this community. I've learned a lot from those calling in, and hope that they've learned a lot from participating. And I think that gives me sort of a point to pause and indicate perhaps more clearly that that's really part and parcel with the philosophy of the ECHO model. Is the idea is not for the individuals at Central from the ivory tower to tell individuals in outlying settings that they know the way to do things and this is how to do it. It really is a community of shared learning that's been really rich and robust and that I've learned a lot from and have come to really appreciate. We have put a lot of consideration into the specialists that are present, and there's what I think is close to a comprehensive list here by way of the specialties that we have involved on the line with each clinic session. We've already touched on this a little bit by way of potential benefits, but this calls it out a bit more and is material from the ECHO Institute itself through the case-based learning and some didactic material. Really want to work to include more remote and primary care settings in prevention and treatment where that's appropriate, and get them to gain some comfort in some of the areas where that's appropriate. Because when it comes to some of the substance use disorders, particularly where there are FDA-approved medications, like MAT for opioid use disorder and for alcohol use disorder, there are benefits to be gained from those settings engaging in that practice. And, training historically being what it is, that's been really difficult for those providers to engage in. Over the course of 4 years of medical school training and 3 years of a primary residency, same family medicine, emergency medicine, or internal medicine, and tens of thousands of hours of training, on average in the United States, individuals going through that only get exposed to about 8 hours of training particular to substance use disorders. So I think it makes it understandable that a typical provider, as they enter practice independently, may have some discomfort with trying to tackle these issues. And surveys do indicate that part of the issue is that training, and that perhaps if they had more by way of backup from specialized knowledge, they might be more likely to pursue it. And that's been found in surveys of providers that have gone through the data waiver training to provide medication-assisted treatment for opioid use disorders as well. This is a small sampling of some of the curricular areas for our didactic content. Again, while we started with a pretty square focus on opioid use disorders, this year, as of May, we were able, through a different funding stream, to expand on that. And we felt that was really important because we were getting, based on some surveys of our providers, indication that, well, yeah, opioids are getting all the headlines, but there are lots of other things in our areas with which we're struggling, including, as you might imagine, alcohol-related issues, and methamphetamine becoming a big issue, particularly in a lot of our rural areas. So it was really nice to be able to expand on what we were doing and touch on some of these other issues with which general healthcare settings might have contact. So by way of throwing out some thanks to some really important people that got this going. Again, our funding is through the Wisconsin Department of Health Services, and our primary contacts there that have been really supportive and helpful in our efforts and in keeping things on track have been Dennis Radloff and Bernstein Jeffers, head of Substance Abuse Services and Special Populations at DHS, was really the one involved at the front end that facilitated our getting this launched. Our coordinators, Brianna Kleinfeld and Maddie Batsley, that do a lot of the day-to-day with keeping things online with scheduling and bringing in our cases. Matt Fleming is our information technology person. And the names that you see on the right there, Dean Cronj, Sheila Wykes, Ritu Bhatnagar, they're some of our specialist panel, so representing respectively addiction psychiatry and AODA specialty services up in Marshfield and New Start here locally. They've been regular attendees and really helpful in facilitating our discussions. This last name, Allison Miller, I put an asterisk by because I think this is a really key sort of individual as echoes get going. She's a local primary care provider and an early adopter when it comes to medication-assisted treatment provision in a primary care setting, and she's brought a few cases to us. And for those thinking about getting an echo model going, these are, the folks that I think are really going to be key in making these models successful. Again, it's less about the specialists and more about getting support out to these areas and folks like her coming on and getting in the trenches and providing this care and discussing challenges that might come up in the course of management has really been the set of things that contributes to rich and helpful discussion and learning on the part of the community. So again, this is the information on the venue itself for those that might be interested in checking it out or getting in touch if there's desire to get more information about launching one of these projects. And with that, I have left a fair bit of time for discussion and to see what questions folks might have about this model generally, what we're doing in Wisconsin, or what else can be done with it.
Thanks, Dr. Brown. We do have one question from one of our participants who asks, I'm thinking medication-assisted treatment would lend itself well to this approach.
Yes, and that's been interesting on our end. As we were launching the opioid echo, we really thought that's who we were going to be hearing from. And, maybe a function, I think, early on as we were getting going of that not being out there in some of the communities that we were reaching out to a lot. We're starting to see more uptake, and so our hope is that there'll be more questions coming up in our echo sessions. Allison Miller, I already mentioned, has come to us with some of those cases, and we're hoping to build on that and redouble kind of our marketing efforts. We also do some of the data waiver training here. DHS provides some of those, and so we're always kind of looking for those venues as well to get information about the session out there and really try to reach that audience too in those contexts, and also the annual rural healthcare meeting here and things along those lines. So I think that's an important consideration is, yeah, I agree. Medication-assisted treatment is something to get out there in the context of this model, and thinking about how you can reach that target audience is something where we've done some targeted efforts, but continue to think about reaching the right folks with this model. I also see there's a question around the most pressing substance use disorders in Wisconsin Northwest counties. And I went fairly quickly through those maps, but there were definitely a couple of hot spots where opioid use disorder was fairly prevalent, injection drug use, and in places where we're seeing injection drug use rates continuing to go up, it looks to be a combination of both opioids and methamphetamine. And when rural counties in Wisconsin are surveyed, well, with a focus on rural healthcare providers, often in those areas, methamphetamine is cited as every bit as much a problem, if not more a problem, than opioid use disorders. So that's an issue that we have very much on our radar is methamphetamine. And also alcohol. In the context of the hotline that I made mention of, actually, that's been our most frequent request for advice over the phone, has been from primary care providers seeing someone in their office and asking questions. The most frequent ones have been, I have a patient who's drinking this much fairly regularly on a daily basis, wants to quit or cut down. What do you think so far as withdrawal management? Is this something that we can work together on an outpatient basis? If so, how? Should I be thinking about referring them to a dedicated detox facility or hospital? The second question under alcohol use disorders has been related to pharmacotherapy for ongoing recovery and medication selection around naltrexone or acamprosate, things along those lines. Here also we've gotten less by way of questions related to opioid use disorder management and prescribing of buprenorphine-related products. Have gotten a fair number of questions related to opioid tapering in the setting of pain management if folks are struggling with opioid use.
Thanks, Dr. Brown. We have another question. If these programs are directed towards physicians in rural areas, how do they learn about Project ECHO? Do you reach out to various providers, or do you wait for them to reach out to you?
Oh, good question. I did not make that clear. So the way we've pursued that here was we reached out to large health systems in the area. So here, UW Health, Bellin in the Northeast, SSM, and then we also have a strong collaborative relationship with the Rural Wisconsin Health Cooperative. That's a large network with 42 affiliated hospitals and affiliated clinics, and we really use that as an initial set of points of entry to try to reach those populations. And we'll send out periodic blasts through those networks to try to recruit. I also made mention of the fact that we try to keep our eye out for conferences where those audiences might be specifically targeted. And there's a rural health conference annually in Wisconsin in June where we've had a presence and try to get word out at that venue as well. So something where we're always keeping an eye out for ideas, but that was where we started.
Great. We have another question. Are there requirements to participate in the Project ECHO series? Would this be strictly medical professionals or potentially criminal justice professionals working with the patients, with substance abuse patients?
Oh, good question. So to call into an ECHO as a participant, no, there aren't requirements. With the information available on the website for ours or others, you can fairly easily search up through Google ECHO sessions. I would expect there might be one in your area, and there should be information on registration available there. And I mentioned the Zoom platform. So there, you won't need to download any special software, and there isn't cost associated with that. With each session, a link will be provided, and you'll get hooked right up to it, and that can be done through, any computer or even mobile technology. So a tablet or smartphone can be used to participate as well. And no, our audience for our ECHO is pretty multidisciplinary, actually. I was emphasizing primary care providers, so I'm a primary care provider, so I look through that lens at the world, and so I didn't completely address that. We have also counselors in rural locations and with specialist treatment agencies in social work, in nursing. We've had some local pharmacy participation. The other thing that's been really nice to see is healthcare trainees, counseling and social work trainees coming in as part of a site. For example, at our last session, New Start is a specialist treatment program locally in the addiction psychiatry. Attending physician there had a counselor with her and a medical student and a social worker, and so yeah, we've had fair diversity so far as that goes. The case presentations also have come from a variety of professionals as well. I was focusing primarily on Dr. Miller because she's presented a couple quite recently, but we've had presentations also from counselors and with advice from other counselors. So no, the participants are not uniquely physicians, and the contribution from professionals in other areas I've seen is really important, actually, and a really important contribution to the community and the learning. And then I see, does our Project ECHO work with tribal communities in Wisconsin? And that's a really great question, and we do need to reach out more specifically there. We do have participation from an FQHC in a region of the state that serves a tribal community, but the extent to which we're attaining that reach, I'm not completely clear on, and it'll be, I appreciate that question for that reason. That's something where I think, you know, as we're looking at our evaluation and, you know, in targeting that, that's something we'll be looking into. You know, and that was actually a question that came up on our last session that was really helpful to us, and where we're probably going to be targeting some didactic education, because there are, I think, as you all likely imagine, some issues around cultural sensitivity in our attention to care in tribal communities when it comes to these issues, and so we're going to be planning some didactics around that issue as well.
We have another question. Yeah.
So I thought I saw a question, how long will this be running? Well, we hope indefinitely, but right now we have another 2 years under our current funding, so at least that, but we will continuing to be doing whatever we can to ensure that this is a sustainable effort.
Thanks for those great answers, Dr. Brown. I think we'll watch the chat box for a minute, see if we get any additional questions.
Yeah, so we'll wait for that, and I have my email up there. Again, if there are any attendees who have their own interest in starting this up, questions about what that looks like, feel free to reach out by email. If I can't answer them myself, again, one of my coordinators, Brianna Kleinfeld, I can connect you with too, who has a lot more sort of the day-to-day knowledge of the running of things, and we're happy to help out so far as that goes.
Well, it looks like we don't have any additional questions for now. And thanks, Dr. Brown, for including your email address up there for people to contact you with their questions or to sign up. And I just want to alert everyone to the other notes panel that gives you the address of our website, That's where you'll be able to find a recording of this webinar as well as the PowerPoint slides within 1 to 2 weeks.
Okay.
So
Great.
Thanks, everyone.
Yeah, and real quick, if folks are interested, then I just was pulling it up on the calendar. So then our next session, if anyone's interested, then will be starting at 12:30 on Friday, December 20th, where we'll have case presentations, and I'll be doing the didactic piece that day, and I'll be talking about substance-related issues in older adults.
Thanks, Dr. Brown. That's a really important topic. So thanks, everyone, again for joining us, and thank you, Dr. Brown, for your great presentation.
Great.
And
Thank you. Thanks for having me.
Yes. We'll be signing off now.